restoration, and the presentation will last about 45 minutes, and it will be followed by Q&A for about 15 minutes. Education is very important, especially when new techniques, new solutions are involved, and there is no better person than a specialist, an endo-resto specialist, to share his own experience. So don't be shy, and feel free to write your questions in the chat box during the presentation. We will read them at the end, and Andy will answer them one by one, hopefully, if there is not too many. We will also most probably send you a follow-up email within the next few days, which you are very welcome to answer, especially if you have some interests in the products that will be featured in the presentation and in clinical cases introduced by Professor Ounsi. And we will be very pleased to assist you further and prepare any introduction offer if it's what you are looking for. So feel free to basically switch on your camera, as it's always nicer to see faces. In a few words as well, for those who do not know PD, Produits Dentaires, it's a Swiss company established in Vevey, and we will be actually celebrating our 85th anniversary tomorrow. The company is specialized in endo solutions, and especially in obturation and in irrigation. So I will leave the mic to Professor Ounsi, who will introduce himself in details, and I wish you a very good webinar.
Well, thank you very much, Benoit. I'm very happy to see all of you again. I promise I will not introduce myself in too much details, otherwise the 45 minutes will be gone. I'm going to, if you don't mind, share my screen. Can you please confirm that you're seeing the slide?
Confirm.
Yes. Confirm. Excellent. So, good evening, good morning, good afternoon. I don't know each of you where you guys are from. I'm in Kuwait. It is 8 p.m. in Kuwait, so it's relatively early. And I have the pleasure of giving this presentation. So just a quick word, background about myself. So I'm a full-time endodontist. I worked in Lebanon until 2007. And now I am in Kuwait since 2007, so it's been a long time here. I'm also an educator. I worked in St. Joseph University from 1990, so 17 years. Then I worked another about 15 years, 17 years, something like this, at the Lebanese University. And I am, since 2011, visiting professor at the Department of Medical Biotechnologies of the University of Siena. I am a researcher. I am very interested in research, and I give lectures. I have more than 200 conferences, and I have more than 50 indexed papers. So, a quick word. For the sake of transparency, I have to tell you that I do cooperate with these partners in the industry. They give us products mainly for our research. I do occasionally run courses for them. And today, this lecture has been requested by Produits Dentaires to present some of its new additions to its dental portfolio. I will describe the products, of course, but we will also be talking science and clinics. And I'm sorry if I have to drink often. I've been talking for the past 3 days. Anyway, the products that you are going to see in this presentation, as far as I'm concerned, are for demonstration purposes only. I do not endorse or recommend any manufacturer or product. So as you all know, we are now in the era of minimally invasive dentistry, and doctors wish to abide by this concept. Now, as an endodontist, I can tell you that it started with us using magnification. Right? Having the microscope in the office changed a lot, was a big game changer. I've been using the microscope since the early 2000s, late 1990s. Now, using the microscope allowed us to do things that we could not do earlier. It actually kind of expanded our senses and allowed us to perform endodontic treatments through smaller axes with better and more predictable prognosis. Now, it is a fact, when you start using the microscope, you tend to actually use it for everything. I use the microscope to do cleaning. I use the microscope to do restorative dentistry, and of course, to do endodontics. The next major step that happened in endodontics was the advent of hydrated calcium silicates. This is a new class of material that was on the market, and it allowed us to change the philosophies of treatment. Our philosophies of treatment are moving towards minimally invasive. So our treatments also tended toward having smaller root canal preparations. And this was made possible because tricalcium silicate can be considered as a filler with eventually an added single cone of gutta percha. Simplifies the filling procedure because the properties of the material are completely different from the properties of resin-based sealers. Now, tricalcium silicate started with mineral trioxide aggregate. This is an old image of the ProRoot MTA that I have. Started in the late 1990s, and it was primarily used for iatrogenic repair with excellent results, I have to say. Now, MTA came as a replacement of the traditional material used for direct and indirect pulp capping, that was calcium hydroxide. Now, the results were often mitigated to the point that some practitioners had no confidence in the outcome of their treatments and preferred to go directly to root canal treatment rather than attempting a vital pulp therapy or a direct pulp cap. It's the same name. Vital pulp therapy is the fancy name for pulp capping, direct pulp capping. Now, the point is that the dentin bridge that was supposed to happen when you place calcium hydroxide was often elusive on radiographs and in histological studies. As a point of interest, I came across a paper when I was a fifth-year student, so a long time ago, and that is entitled Disappearing Dical. Right? It was published in the British Dental Journal, and it was a case series showing that dical would disappear after a while on radiographs when used as indirect pulp cap. For the story, this is when I stopped using liners under restorations. Now, MTA is a bit different, but the problem that we had with the gray MTA was that it used to discolor teeth because of the tooth translucency and the dark gray color. So this is why they developed the white MTA. Now, the problem of discoloration did not go away because the opacifier that they used was still bismuth oxide. And that opacifier reacted with the sodium hypochlorite and that we used to disinfect the pulp wound and produced a dark compound, and this discolored the tooth. So these opacifiers will later change to zirconium oxide and tantalum oxide, and that problem was solved. As I told you, MTA was described first as for perforation repair material. As you can see in this case, which is an old case, after a stripping perforation in the mesials, the patient was referred to me, so the treatment was performed, and MTA was applied to the perforation after treating and sealing the apical segment. And I have to tell you that it was not easy to just seal the apical segment and leave the rest open. I had to use a technique called the sectional technique. So you just take a section of the gutta percha and you apply it in the apical part. And then you fill the rest with MTA, and you have the recall. Like this was like maybe 4 years after, 6 years after, something like this. So the tooth was still in place at the time and the patient was happy. The use of tricalcium silicates, one of the uses is sealers, but I don't want to talk about it, which is why I actually started with the third one. Benoit, do you see my arrow on the slide?
Yes, we
Yes?
do.
All right, perfect. Thank you. So I'm not going to talk about sealers because this is not the topic, but I am definitely going to talk about retrofilling and vital pulp therapy when we use the MTA. So let's see first surgical. So I personally don't do a lot of microsurgeries, so I relied on a couple of cases of my friends. So this is from Professor Alam. You see you have a very large lesion, and when he did the resection, placed his MTA, the lesion resolved. Also, this is another case by Dr. Emanuele Ambu from Italy. And you see, when you work under the microscope with the proper magnification and proper light, the images that you can have and the vision that you're actually sitting inside the cavity makes things easier. Now, the use of MTA, this is an in vitro histology case published by Domenico Ricucci. On the left, you can see the root and filling material that is visible through the connective tissue that is covering the root. Now, if we cut this part longitudinally at the level of the line, the overview shows that the material is lined externally by connective tissue, which is here. And if we magnify further, we can see new cellular cementum that has been formed over the resected root tip and on the tricalcium silicate material directly in contact, which is very, very good, which we did not have with previous materials. So this is really optimal healing. In the same way with vital pulp therapy, we used MTA. So this is a case of direct pulp cap. In this case, I used tricalcium silicate, which is a putty. So just quick and dirty, these were the clinical steps that you have to take when you do a direct pulp cap. So you do need to use the rubber dam. The caries has to be controlled with a tungsten carbide round burr, which is sterile. You need to change this burr when you move from an infected area to a clean area. You need to perform hemostasis control with a wet cotton pellet, usually soaked with sodium hypochlorite. This disinfects at the same time. You rinse with sterile saline, then you place your tricalcium silicate, you place a glass ionomer protection layer, and then you do a direct composite restoration. Now, these techniques give good results. So this is the same patient 1 year later. You see that everything was fine. He was happy. And actually, he did not come for the recall. He came because he had the same problem on the other tooth, but I could not save it, unfortunately. And it ended up with a root canal treatment. Now, when tricalcium silicate is compared to calcium hydroxide for pulp capping, there is a general consensus that tricalcium silicates perform better in terms of the presence of a thicker mineralized barrier. Also, we have less pulpal inflammation, and the pulp stones visible here are embedded in a healthy connective tissues with fibroblasts and a lot of collagen bundles. Now, whether for repair, surgical endodontic or direct pulp cap, like in this case where you have a very deep pulp cap, the clinical problem at hand was always the placement of the tricalcium silicate. It was always very messy and inconsistent. Like this is a deep pulpotomy. Now the challenge here was to place the tricalcium silicate without messing up the dentin walls above it to be able to seal it with a bonded restoration. And you can see this is the recall after about a year, and you see the dentin bridge that is formed. It's very, very clearly seen on the X-ray. It's a big difference between when you use a tricalcium silicate or an MTA based product, or an MTA, actually not an MTA based product, or you use calcium hydroxide. Now, the MAP system is a potential solution to this problem, to this messy problem of placing the product. Now, it is made of a syringe and different needles adapted to the procedure. The size of the canal and the volume of material required will actually direct what needle you're going to choose. And you also have the MAP VPT, which is vital pulp therapy, which is an extension of the previous classic MAP system. Now, your needles come in 3 different color-coded sizes. You have yellow, red, and blue, right? Number 0, number 1, and number 2. And we're going to talk a little bit later about the vital pulp therapy needles. Now, the shape and the material of the needles change, and they are specific for each clinical condition, and we will be talking about this in detail. The way the needle is placed is linked to the plunger, actually, is inside the needle you have a plastic silicone, actually, a silicone band that pushes inside the needle. To link it to the plunger, you have to clips this part of the plunger to the this part of the plunger that is in the needle to the plunger that is in the syringe. And when you put everything together, this is a magnified view, so you can see here the mechanism. This goes inside the needle, and this part is linked to the plunger. So when you pull the plunger, this goes out. You push the plunger, goes in. So the way it works is like this. This is a small video. So you see that the tip here is nickel titanium, so you can bend it the way you want, and it will maintain the bend. And when you push the plunger, it pushes everything outside. So you start by just mixing the MTA until you get a wet sand consistency, right? Now the consistency is going to be a function of the work that you are doing. Now you remove the excess from the outside of the needle, and when you push your plunger, you're going to get this perfect cylinder of MTA, which you can place in very specific places. Now, with regards to pulp capping, you can use the MAP VPT, but again, we're going to go back to this one. When you have pulp capping procedures, or you have partial or total pulpotomies, or if you have also large pulp floor perforations. We don't see much of those anymore with people using magnification, but we still have some. So these instruments come in handy. When you have perforations inside the root, nickel titanium memory shaped needles can be bent to specific directions, and this will allow you to place your product inside the perforation through the root very, very precisely. You also have curved needles that are designed for precise endodontic procedures using the orthograde approach when you're talking about placing the product very deep inside the root. Or you also have angled needles that are used for retroobturations, whether straight or triple angle. We're going to see them a little bit later. So this is just a clinical example of placing MTA inside the perforation. See, it's very, very precise. The small red dot that you have, I'm going to repeat the video. So you see here, you have this small red dot, that's the perforation. And you just place this inside. It's very, very fast. So it's very convenient, and it's very clean. So just to give you an idea, in this specific case, I had 2 perforations. I had the floor perforation and I had the wall perforation. And this is a retreatment. So this is, I had to find the distal canal. These were the 2 mesial canals. The gentleman was trying to find the distal canal. He made the 2 perforations. Now you see that when you place this, you have to place it before you start. So I start by looking for the canal, I find it, and then I have to repair the perforations. And then only I can go in the canals. Now, if this is messy, which used to happen before I was using the map, going and cleaning inside the canals was a little bit challenging. Right? So even mesial canals, distal canal, and the floor perforation, wall perforation here, floor perforation there. This is a different use. Here I'm using actually the map to place a little bit of resin right on top of this to be able, this is a bit of resin, just to cover and protect my my tricalcium silicate, so I can actually continue the treatment within the same session. And you see that with a little bit, with the bonding holder, these small brushes, you can actually apply your resin very, very neatly and very cleanly. This is a case that I did a few days back, actually. So this is just to show you. I'm going through the whole thing. It's about like a 3-minute video. So first, I'm removing. So this is the second session. And it has its importance. So here I am removing the temporary filling, under which I'm going to find. I'm trying to go to speed it up a little bit. Under which I'm going to find my Teflon that I used to isolate the floor of my cavity. So this is done during a regular session, and I don't take an afternoon to make a video. All right. So here you're going to notice that anyway. So these are the canals, and this is the perforation. I'm going to clean a little bit with ultrasonics. Now, why did I do it in 2 sessions? Because at the locus of the perforation, here I'm cleaning the perforation with the number 30. At the locus of the perforation, the media is acidic. And when the media is acidic, any tricalcium silicate that you place is not going to heal. So I place calcium hydroxide the first session, non-setting calcium hydroxide. This is going to move the pH of my media to alkaline, allowing my MTA to set. Here I'm choosing the size, and you see that I use the number 2. I load the needle. I'm using a putty. So you see I can use MTA as powder and liquid and as putty. So you load it. You're going always to have a little bit on the outside. You clean it, right? You clean the excess, and then you place it. You try the perforation, obviously. And I'm showing you this for a specific reason. When you're going to see the X-ray, you're going to understand. So I place the needle now, and I'm going to stabilize the needle. So I'm injecting it, literally. It's literally an injection. I'm going to stabilize it because I don't want it to move. When you use a putty, it's actually harder to push. And you see here the result. This is calcium hydroxide, by the way. And you see that I did it in my assistant was looking at the movie. Actually, she didn't tell me that I was at the border of the camera. I'm using the brush to clean. There we go. And I'm going to temporize again because my patient came between appointments just to do that. And he left. So that's the clean part. And then I place my Teflon cavity again. So just to show you, this is the case that you have just seen. And you see the length of the perforation on the floor. All right. And I just closed all this in one go with the MAP VPT, with the MAP system, sorry. All right. This you see here the precision of placement of the product using this device, and it becomes even more important when you have cases like this one where you have a perforation that is deep inside the canal that you have to take care of. Right? This is a C-shaped canal with a perforation that was repaired. The perforation was due to the post. And that's the recall at 1 year. That's healed. So this is quite interesting as a device because you place very cleanly the product and we don't have the problem of cleaning after. This is quite interesting. So placing also inside the root canal, like in the previous case for the perforation, you can also fill the apical part when you have large canals. You have very, very good control over what you're doing and you know exactly where your tip of your needle is. You can actually take an X-ray with the needle to see where you are if you're not sure. And then you can actually inject and close the whole thing. And this is the completed case and the recall. Another case of where it's actually helpful is when you have a resorption. So in this case, you have a resorption. And you see that also before dealing with the resorption, you have to build the pre-endodontic buildup, and we're going to talk about this a little bit later. But you see that I also have placed calcium hydroxide, because when you have an internal resorption, you have multinucleated clastic cells that you need to destroy, and these are not destroyed by sodium hypochlorite. You are forced to place this calcium hydroxide for 2 weeks, and then that's the final case. And this is the view with the CBCT. This is how it looks. Another thing is when you use these instruments for surgery. So these are triple angled that you can use for molars. And just to give you an idea, this image is from my good friend, Dr. Guillaume Joigny from Paris, from France. And this is how he places his tricalcium silicate. He uses it as he can mold it with his fingers as a cavity. But imagine how delicate this is, working at very high magnification. That's very high magnification. So even the patient breathing will actually make your hand move. You have to be extremely delicate, extremely precise. And imagine how easy it would be to place it actually using one of those tips. Much, much easier. So cases like this one that you have seen before are actually, oops, there's one from this. These are for molars. You cannot use the straight ones. You have to use the triple angled ones that are angled, whether the molar is on the left side or on the right side. If it's up or down, the angulation changes. So the nice thing is that these actually work whether you're working with an MTA in the form of powder and liquid, or if you're using a paste. In both cases, it works. The problem with the paste is that it's harder to extrude and harder to clean later on. But with the MTA, is much smoother as a movement. When you use the paste, you have a resistance, and all of a sudden the paste comes out, and it might actually cause a little bit of pain if you're closing your perforation for the patient. So let's talk a little bit about the other version of the map, which is the VPT, the one that is used for vital pulp therapy. Now, vital pulp therapy has been discussed in the literature, and there are studies that show that it is actually, you have a success rate between 90 and 100%. You have this paper from the American Association of Endodontists that actually goes into the details of each part of the procedure, amongst others, screening and case selection, rubber dam isolation, using sterile burrs, like I said, changing the burrs between infected areas and cleaned areas, using sodium hypochlorite to disinfect and obtain hemostasis, and using calcium silicate in contact with the pulp to maintain vitality, etc. So this is a very good read. I recommend it highly. This is another position statement, but this one is from the European Society of Endodontology. And they make summary key recommendations that are more or less like the ones from the American Association. But they add that after vital pulp therapy, the teeth should be carefully monitored for at least 6 months. And you have to supplement this with x-rays at 1 year. And if the symptoms persist, then you possibly may have to move to a full root canal treatment. You need to do cold and electric pulp testing to verify that your treatment actually worked. But also they add at the end, and this is typical from the European Society, that although this area, I'm reading here, although this area is likely to modify in the future, this ESE position statement must be cautious in recommending treatments of choice that are preliminary and not supported by robust long-term evidence. So basically, they're being politically correct and gaining plausible deniability. But anyway, so these are the 2 needles for the MAP vital pulp therapy. And if you don't remember them, this I noticed a few days back when I actually was doing the presentation. I used to keep asking how large they are. Actually, there are two tips. One tip which is white, which is 2.3 millimeters, and the other tip is purple, and it's 3.4 millimeters. So you see that these are quite large when you talk about small perforations or something. So these are actually designed for something else. But if you want to remember the numbers, it's very easy. It's 2.3 and 3.4. So 2, 3, 4. You're not going to miss it. It's just a small hint. Right. So this is a case where I had a very wide perforation. So this is the preoperative that I got. And so I retreated the canal, placed calcium hydroxide in the access. But unfortunately, I did not place collagen beneath my perforation, which led to the extrusion of the tricalcium silicate. But this was proved not to be a problem. This is a 2-year recall, 16 months actually, and the tooth is asymptomatic and fully functional. Other case of vital pulp therapy happen especially in children, actually, between anywhere between 9 to, let's go, 14, 15 years. Because this is the period where the caries gains in importance on the sixes, uppers or lowers, and the patient starts to learn how to do oral hygiene because his parents didn't follow him or whatever. So you very often, while cleaning the caries, you have an effraction of the pulp. Sometimes it is small, sometimes it is large. So the idea is you deal with this as either a pulp effraction or a pulpotomy, depending on the case. And you're going to need to place your tricalcium silicate. So if you have a small effraction, like in this case, so you place your tricalcium silicate with a small map, to be sure that you have closed this. And then with the larger map, the map VPT, you cover the whole area, the whole surface. This is the recommendation from the AE. You cover the whole remaining dentin from the roof, and it acts as an indirect pulp cap, and then you build on top. Right? So this was a patient. You're going to see that this date is 12 September 2024. This is another patient, same thing, 12 September 2094. This is the sister. Right? These are two sisters. So same thing with the same problem, perforation here. And you see here, I did not cover the pulp. I just covered the dentin with the product. The MAP VPT also helps when you have a large root, a large floor perforation, like this case. All right. You can see that the size of the perforation, a small MAP needle will not be enough. You will need to use a larger MAP needle to deal with this. Right. This is a perforation repair on 36, and this is the final case. One last thing about vital pulp therapy is in vital pulp therapy of mature permanent teeth with irreversible pulpitis, the immune defense mechanism and the regenerative potential of the radicular healthy pulp is preserved, right? In contrast to root canal treatment, where you actually remove everything. Now, for a long time, it was the understanding that you could only do this on immature teeth. Immature permanent teeth. And when it was an adult, when you had a perforation or a pulp exposure, you needed to go for a complete pulpectomy because it would not heal. But this is just to show you, this is a case that I did. Of course, here case selection is very important. And there is a way to deal with this. It's always delicate. This patient is actually a restorative dentist in the clinic where I work. So he had this large caries on the upper 7. And as you see, when I cleaned the caries, I had quite a large exposure of the pulp. I managed to have a hemostasis, and I told him I was going to try a direct pulp cap. He agreed. In this case, I have no problem because he understands the risks and he understands the benefits. And so this is the case in 2016. This is the case. This is the last X-ray I have of the case. 2023. The tooth is still vital, and it works in mature teeth for adults, provided you do a proper screening and protect yourself, you have to explain to the patient that you might end up doing root canal treatment. From the financial standpoint, it is, of course, more lucrative to do a root canal treatment than to do a vital pulp cap. And it is actually interesting because this is a subject that I raised. I know that Americans are very good at this, much better than we are. I am French educated. I studied in France, so we don't move in the same way. And I asked him, how did he do? What did he do to how did he bill his patient? So just again, as an indication, you might use it, you might not use it. What he told me is he billed the root canal treatment. He did the vital pulp therapy, but he billed the root canal treatment. If there were symptoms within the next 6 months, then he would do the root canal treatment for free, having it being paid. And if there was no symptoms in the first 6 months, then he would keep the money. And if later on there is a root canal treatment that has to be done, the patient will have to pay for it. So it's a solution. It's not the perfect solution. I'm not even sure. We have a huge problem with this. And I know that we have a huge problem with this in Kuwait, with the insurance companies. You cannot explain this to an insurance company. So yeah, that's a problem that to which we will have to find a solution. Maybe Produit Dentaire will come up to the solution, who knows. So now that we have spoken about vital pulp therapy, I would like to talk a little bit about the second product that I wanted to share with you, which is SwissMat, which is a matrix system. It's a complete sectional matrix system. So it's obviously for use in class 2 restoration. So the sectional matrix, there is a lot of literature on class 2 restorations, but there is very little literature on actually the matrix itself. There is a literature on what products you use, what techniques you use, but the matrix in and of itself, there is very little literature. And these are 2 papers that I found that actually come to the same conclusion, that using a sectional matrix gives better contact points, better contact tightness, right? That the second one, circumferential matrices, were found to be more superior with respect to preference and time efficiency. This is for pediatrics, if I'm not mistaken. And sectional matrices were preferred for ideal contacts. Now, the children in this study accepted circumferential matrices because they were faster, right, to place. But the result that you want, if you want a good result, then the sectional matrix is definitely preferred. This is how it's presented. So this is the box, the organizer box. So this is the, if I'm not mistaken, they will correct me if I'm saying something stupid, but this is the organizer box. This is the introductory kit. So you have a selection of wedges, you have tines, you have the clamp, and then you have bands of 3 sizes. And they are placed, what I found to be extremely interesting is the fact, and this is very good for my assistant actually, because she's the one who does this work. Everything is labeled with the references and everything. So if you need a specific thing, you have the reference, everything is already ready for you to use. Quite honestly, I have not tried to check this, this code here. I don't know where it leads, probably to a PDF file online or to their website. But basically, this is it. So you have the 3 sizes, you have the 3 sizes of tines, you have the clamp and the wedges. So this is the view. I don't know why I'm showing you this here, but it's here much better. Now, the idea also in having all these places empty is that if you want to add to whatever you have spaces, you have space and you don't have to put them in your drawer, which is quite interesting. Yeah. So anyway, let's talk about what's in the box. So these are the tines. These are the pieces that actually come in contact with the teeth. And these are the tooth sizes that come in the introductory kit, which are the medium and the small. The medium is gray and the small is red. The third size is the large, which is black. And it's designed for teeth that have a lot of loss of tooth structure. When you place those tines on the ring, on the clampable ring, this is what you get. So you see this shape, the scalloped shape that replicates the shape of the tooth, and this is interesting. This is interesting because if you take what I have been using up to very recently, you see that this is what I get, right? So I got these images from my friend Simone Grandini. He has much better images than I do, and I got his permission to use them. So you see here, this is another type of clamp, and it does not apply perfectly. You still have those gaps where very often I have to place Teflon to push the matrix on the tooth, right? To circumvent that, you see that this is a idea from Jordi Manauta. He did adjustable, actually, adjustable clamps. So these are not standardized, personalized. So he would do this, and then when he places this, it will actually seal perfectly, and he get the contacts he wants. And then once you have this, very often when you place this, what you have is you have this that goes in a V shape. This is, once you place it, the first thing you do, you have to check for the adjustment at the apical level, right? And then you have to recontour this using a burnisher ball or something similar. The other thing you have in the box is the clamp holder. The clamp holder is very, very interestingly made. You have this design, which is a non-slip design, because when you're going to hold the clamp, you need this because the clamp that you hold, this ring is actually quite, this is a double spring ring. This is extremely tight, so it will hold your tines in place and your matrix in place very well. So when you place this on a model, so this is a model, and I took those photos. This is just to show how important it is. So when you look at the tines from this view, you see that they're well adapted and you're very happy with the result. But when you look from a different view, you see that actually they're not well adapted. This is why it's interesting to have several sizes of tines that are going to come and actually fit perfectly and place your matrix and contour your matrix better than actually having something. Of course, it will not fit everything, but having several sizes actually gives you more choice. Now, when you place the tines, you need to remove them. The tines are autoclavable, so you can reuse them eventually. The ring, of course, is autoclavable, but removing them, because when you place them, they're actually well set, and removing them is a bit hard. So what I found to be very, it actually came instinctively, very useful, is actually to use the forceps themselves. You place them here, then just to open and you pull, and then your times will come out, both of them at the same time, in a very, very clean manner, right? Now, if you take a look at the bands, these are the bands that are in the box. You have three sizes. You have the premolar size, which is 5 millimeter in height and 0.04 in thickness. Everything is 0.04 in thickness, so they're quite thin, right? So you really need to place them properly from the beginning. Then you have the molar one, which is 6.4 millimeters in height, and you have an extended molar, which is 6.4 millimeters. Now the first two would be for cavities that are supra or juxtagingivals, and the one that has an extension is, of course, for subgingival cavities. If you take a look at the wedges are quite interesting. They're V-shaped, and I was surprised when I used them for the first time. They're quite, despite the fact that they are plastic, they're quite rigid. So they hold their ground and they don't deform easily. So they are going to put your matrix in place quite firmly. So you have extra small, medium, and large. I don't agree with the way they divided the box in which they come, in which the assortment comes. I'll tell them about this, but it doesn't make sense to me. It can be changed. The important thing is they have a hollow design. So these are the wedges seen from the bottom. Right? So this is the top and this is the bottom, and you see that it is hollow. And this is interesting. First, because it's going to respect your papilla when you place it, right? So you have a good adaptation. And if you're not happy with the adaptation, because it happens, depending on the anatomy of the root of the tooth and at the level of preparation, you can actually stick a smaller wedge in the larger wedge and force it to be applied better on the limit, right? So this is just a couple of clinical cases. So this is from Giuseppe Chiodera from Italy, a good friend of mine. So this is a pre-op. He's replacing the composite on this tooth. He removes the amalgam. Always place the wedges before removing the amalgam to protect the cervical area. Then places his bands, matrices, etches, and then he can place the ring with the tines. He rebuilds the wall. That's the way these guys work, right? And then he rebuilds the distal wall, and now he has a class 1 cavity, and he can continue the treatment, right? So that's just to say, this is another class 2 restoration. This is not by me. This is a case that I got from the team of Produits Dentaires. It's a dentist in France, I think, if I'm not mistaken. They will correct me if I'm mistaken. So this is the placement, and you see the perfect adaptation of the matrix to the contour of the tooth. Because one of the problem with the sectional matrix is, before having this type of tines, was you have a very good contact point, but you don't have a very good a very good contouring of the tooth, and that was the problem. So here you see from a different view, you see the adaptation, and here is the final restoration, right? This is in pediatric dentistry. It's quite interesting. So this is a pediatric case. So you see here, after cleaning the caries and doing the pulpotomy, placing a wedge to clean perfectly the limits. Here you can use you see the size of the needle as compared to the size of the cavity. It is well adapted. So this would be the 3.4 and this would be the 2.3. So this is the violet one and this is the white one, depending on the size of what you're going to restore, right? And now you have the restoration. In cases like this, what you do is you restore one side and then you restore once you have it, you just clean it with a burr, and then you restore the second based on the anatomy that you got. As an endodontist, I could not pass this without telling you that matrices are a major thing. This is the first thing I do when I do a root canal. I do what we call a pre-endodontic buildup, right? There are a lot of people that say you should not do it. As an endodontist, again, it doesn't make sense not to do it, and this is where your matrices come in hand, because when you place it, now you have a class 1 cavity and you can do your treatment, and you have your reservoir of irrigant when you work. So in conclusion, I would like to tell you, I already understood that both the MAP system, whether classic or the VPT, and the SwissMat are high quality products, high quality tools that would make valuable additions to our armamentarium. In my own experience, for what it's worth, so I'm just giving my opinion. That's what I do in my office, and what I'm going to do tomorrow morning, whether people like it or not, because it actually, they have proven their worth in my workflow, and they significantly improved my standard of care, makes things easier for me, cleaner. So the ergonomics are better in my practice also. So I'm going to keep using it. I encourage you to evaluate them yourself, and for your own opinion, if you like them, use them. You don't like them, don't use them. And with this conclusion, I thank you very much for your attention and for giving me the opportunity of sharing my thoughts with you. These slides have my contact information. If you need to contact me, you have a question, something you remembered later on after the Q&A session that is going to happen now. Yeah, so I'm ready to answer any question you may have, and I'm going to yield the floor back to Benoit.
Thank you very much, Professor Ounsi. Thank you for your brilliant presentation once again. So as you said, it's time for questions. Please use the chat box to set any questions, and the team will be very happy to answer. We have enough time.
I was on time. I didn't take too much time.
It's fine, just a few minutes, but we have enough time for questions. Some greetings from Dr. Vinay. Thank you.
Thank you, Vinay. Haven't seen you in a while. Looking forward to see you again. Yeah, question. Where you were mentioning about putty consistency while using VPT. Yes, what's the question?
I think, I don't know if Vinay heard that.
There it is. Is it possible to get the same putty with our regular PDMTA powder? All right, so when you're using the MTA powder, you can get any you will not get to putty consistency in a way that you can actually use it in your hand and change the shape. Well, typing is slow, yeah, I understand. All right, so you can get it a bit harder. So depending on the ratio of powder to liquid that you put. This is what we used to do. This is what I still do. And when I place it, sometimes when I place it, I feel that it's still a little bit too liquidy to my liking. So I use paper points to take a little bit of the water that is in it. But you can actually get harder consistency. You should actually, if you're using the large needles, get a little bit more towards hard than soft. I hope I answered your question. Ultrasonic densification. Quite honestly, I don't know. It's much easier to just pack it because ultrasonics can do two things. It can densify or it can actually blow everything away. So, or create voids also, because what you're going to, when you use ultrasonics, what you're using is, I'm thinking as I'm talking. When you use ultrasonics, you're actually emitting waves. Your insert is vibrating. If it vibrates in the media, it is going to emit waves, and those waves you're going to have peaks and crests, and those are going to you're going to have areas where you're going to be more dense, areas where you're going to be less dense. I think it's much easier and much simpler. You know, the KISS rule, keep it simple. It's much easier to just pack it and with a wide plugger and you're fine. My pleasure, Vinay.
There was one question regarding the compatibility of map system with other materials, but I think Fabien answered the question as well.
Yes. It will work. It will work. I'm using it to place composite, so it will work. You just need to clean it very well.
Perhaps one thing to mention as well regarding the SwissMat system, you have shown the different sizes of the tines. Very nice images. You have even the ability to put, of course, a small or a medium on the left and right side in order to even better adapt to the particular shape of the tooth. So you don't have to always use small on both sides and so on. That gives you even more flexibility and adaptation.
Brilliant. I didn't think of that. See, we don't think outside the box. We need to think outside the box. This is good. This is good. I'll actually try it. I've had some issues with this now. I think this is a good solution. Thank you.
Some more questions?
Either I was very clear or people are hungry and they want to go to and eat.
I'll be shy.
Anyway, if you have a specific question and you don't wish to ask it in the chat, you can just email me, drop me an email. I always answer. Sometimes it takes a little bit of time, but I always answer. And if you need any reference from the ones that you have seen, please email me. I will send you the reference. I have the paper, so.
Thank you, Professor Ounsi. So questions can be sent directly to Professor or to Produit Dentaire as well. Oliver, who just talked before, is our senior product manager, and he will be very happy to assist you.
Now, there's a
question. One question.
Yes, yeah, this is a very good remark. So, Tomo. So, Dr. Tomo, I assume you said in flow prevention first put calcium hydroxide to change the acidity, so to move the pH toward the alkaline, which I agree. Thank you. But doesn't the MTA also does the same thing? Yes. So if you, I've been using MTA since 1990, and the way we understood that, oh, endodontist, perfect, brilliant, there's a colleague. So I've been using MTA since it actually came on the market. I'm older than I look, by the way. So when we didn't understand the physical-chemical properties of the material and how it worked, because you know how it works in dental. When something is new, you don't read about it. You just buy it and start using, and then you have problems, and then you start reading to understand what's the problem, and start asking questions. So I started using it, and sometimes I had perforation. So the first way it was done was place the MTA, place a wet cotton pellet on top, because this is what it needs to set, send the patient home for 48 hours, he comes back. We did not have the MTA with accelerator at the time, or we did not have the rapid repair materials that we had. So you place it, the patient comes back after 48 hours, the MTA is still wet. You remove the MTA, you place a new MTA, you send him home, comes back after 48 hours. It is set. The first MTA did the work of the calcium hydroxide. It alkalinized the media, and the second MTA that you place will have set. So this is why, again, I'm old school and I like to play safe, to cover all my bases. When I have a recent perforation, I can eventually try to go directly for I close and I finish, like you've seen in this case. But when I have an older perforation, all cases, I place calcium hydroxide, I wait, and then I place my MTA. I don't know if I answered your question. So the MTA will do the same thing, but by doing the same thing, it will not do the rest. Yes, yes, it takes sessions. Unfortunately, this is what we have to do. But what I do is, what you can do is this. If you, from the clinic standpoint, we're talking endodontist to endodontist. I'm giving you my view again for what it's worth. So what I do when I have cases with a perforation, first I locate the perforation, like you have seen. And then once I have the perforation, normally I can close it with anything during my work. And I clean the canals, because there is no point in repairing the perforation if you cannot access the canals. So I clean the canals. Once I clean the canals, I remove my sodium hypochlorite, dry my cavity, place calcium hydroxide in the canals and in the perforation. So this is my first session. Right? He goes home, comes back after 15 days. I remove the calcium hydroxide. I fill my perforation and I protect it with glass ionomer, with anything. You don't need water from inside the access cavity. The dentin contains enough water for your MTA to set. Plus, your MTA on the other side is in contact with the periapical tissues. So you also have humidity at that level. So I hope I helped, or it makes sense to you. Try it. Let me know if it works. My pleasure. Where are you from, Dr. Tomo? I'm not sure he can hear me. Or he's typing, and typing is on North Macedonia.
North Macedonia. Okay.
Haven't been there yet. Hopefully someday. Skopje.
Well, if there is no other questions, I think we can end up the discussions. We spent a bit more than 60 minutes altogether. Thank you very much, everybody, for your participation. You are very welcome to follow our social media pages. We are very active on Instagram, on Facebook, on LinkedIn. You can contact us through these pages, visit our PD Dental pages as well, website. And again, we will probably follow up with an email in the next few days. Thank you very much, everybody, and bye-bye.